Our third topic is gastroenterology, and we will be featuring Stephanie Norman, who is a Lynch syndrome colon cancer survivor, who is also living with a brain tumor, as well as Swati Patel, who is the Associate Professor of Medicine and Director of Gastrointestinal Cancer Risk and Prevention at Prevention Center at the University of Colorado Anschutz Medical Campus. Again, live question and answer will be held following the presentations, so submit the questions in the chat feature on the Zoom. Ignore my dogs barking in the background. If you're listening on Facebook, we will do our best to get to any questions submitted in the comments section as well. Take it away, guys.
Hi, my name is Stephanie. I'm 27 years old, and I'm a two-time cancer survivor living with Lynch Syndrome, strand MLH1. I'm also living with a Lynch-related brain cancer, but I'll save that story for another day. So, I was 22 years old when I first met Lynch, and that was all thanks to a softball-sized mass in my colon. This was after about a year or so of symptoms and being in and out of the ER with a new diagnosis and prescription every time. From, oh, you just have a UTI, or here, take some Mylanta, you'll be fine, and so forth. But obviously nothing helped, so I had to keep going back for answers. My stomach was bloated and hard as a rock. It hurt so bad I could barely eat anything without feeling sick or being in pain. My stomach hurt so bad all the time, but the doctors just kept sending me away with a new prescription or a new diagnosis every single time. And so when the ER finally agreed to do an ultrasound for me, I could barely walk. I was in so much pain it legit hurt to move my body. My face was pale green, and I weighed just 102 pounds, when months before that I weighed like 145 pounds, and no one thought anything of that. And so when they did the ultrasound, they were actually looking for gallstones, but to their surprise, they found so much more than that. They found a softball-sized mass in my colon and a large cyst on my left ovary. I was high as a kite on morphine, and I was then told I had 2 hours to prep for surgery, and that I might wake up with a colostomy bag attached to me, and that I would also probably wake up with just one ovary. So I had 2 hours to process all of this while high on drugs. Well, pain medicine. But so luckily they were able to remove all of my all the mass in my colon, and luckily my ovary was benign, but it still needed to be removed. I also had severe bowel blockage. I had severe bowel blockage to the point where nothing was going in or out of my body. I had to have half of my colon removed. It was a right hemicolonectomy, so now I have a semicolon. And then soon after all of this, I then found out that my colon cancer was genetic, and that's when I was introduced to Lynch syndrome. So I truly believe that had we known about Lynch running in the family, a routine colonoscopy would have caught my colon cancer super early, and also maybe the doctors would have listened to me a little bit more. But even without a Lynch diagnosis, I feel as though colonoscopies should be considered for young adults when experiencing colon cancer-like symptoms. I had to fight so hard just to have an ultrasound done because none of the doctors were taking me seriously. And so I feel as though colon cancer is one of the most preventable cancers because all you really need is a colonoscopy to prevent the possibility of a polyp developing into a cancer. So I personally think the earlier colonoscopy is offered, definitely the better, because it could save somebody's life. So, yeah, that's my story. Thank you.
Good afternoon. My name is Dr. Swati Patel. I'm a gastroenterologist at the University of Colorado, and I'm really delighted to be here today to talk with you about the importance of partnering with your gastroenterologist when living with Lynch syndrome. What we'll do today is talk about really the critical importance of prompt symptom evaluation in young patients and highlight a lot of the important points that Stephanie raised in her story. We'll spend the bulk of our time reviewing the effective tools we have for colon cancer risk reduction for Lynch syndrome, including colonoscopy as well as aspirin. And finally, we'll talk about some of the more recent advances in our field and the many questions that remain. I'd like to start by telling you about a patient of mine who went through a lot of the same things that Stephanie shared with us. He was 33 years old, history of type 1 diabetes, on an insulin pump, who was well established with his primary care doctor for treatment of his diabetes as well as his endocrinologist. He also had an appendectomy as a young man, and he was in the process of finishing his oncology pharmacy fellowship at the University of Colorado when he started to develop rectal bleeding symptoms. His primary care doctor told him that these symptoms were probably from hemorrhoids and treated him with some topical ointments. Symptoms unfortunately did not improve, so about a year later, the patient self-referred for a colonoscopy. The GI doctor who did his procedure at that time found this polyp in his colon and was able to remove the polyp completely, and under the microscope, the polyp showed advanced precancer changes, or what we call high-grade dysplasia, but thankfully there was no cancer. Based on these findings, the doc told him to return in about 3 months to look at that site and make sure there was no regrowth of tissue. The patient got a little bit busy with his fellowship, but did in fact come back approximately 10 months later, at which time the site of the prior polyp removal was well healed into a scar. But curiously, even though he had had a full colonoscopy less than a year prior, the patient had this medium-sized polyp on the other side of his colon. The doc removed that polyp as well, and based on these findings and based on a pretty good quality bowel prep, told the patient to come back in 3 years. As happens, the patient got busy, life went on, he got married, he finished his pharmacy fellowship, he had 3 little kids. And it was really only with the prompting of his wife, because of symptoms of fatigue, which he attributed to having 3 young children and abdominal pain for over a year, that the patient finally came back for his repeat colonoscopy, but not until 6 years later at the age of 40. At that time, unfortunately, he was diagnosed with an invasive cancer of the colon. So when we think about the symptoms that can be associated with colon cancer, the struggle is that oftentimes these symptoms can be nonspecific, things like fatigue, weight loss, pain, a lot of these things that Stephanie experienced for a long period of time before her cancer was diagnosed. But what's really important to understand is that these symptoms can be consistent with cancer. Unfortunately, young patients under the age of 50 who are diagnosed with colon cancer have a significant delay from the time their symptoms start to when they're actually diagnosed with cancer, with patients waiting almost a year from when their symptoms start to when the diagnosis is finally made, compared to less than a month for patients over the age of 50. So it really is critically important to recognize these red flag symptoms as possibly consistent with cancer and symptoms that require an evaluation to rule out cancer before other diagnoses such as hemorrhoids or irritable bowel syndrome are given to a patient. So for our patient, his cancer was screened for Lynch syndrome, as is the standard of care at most places. And his tumor testing was suggestive of possible Lynch syndrome. So he was referred to our genetics clinic. At that time, he reported to us that his sister was actually diagnosed with endometrial cancer within the last few years. His father and grandfather had colon cancer at young ages. He has an uncle who had prostate cancer, and he has a cousin who died of a glioblastoma brain cancer. It's no surprise that when we performed genetic testing, we found a mistake or a pathogenic variant in the MLH1 gene consistent with Lynch syndrome. So we all know that Lynch syndrome is the most common hereditary colon cancer syndrome, and up to 8% of all patients diagnosed with colon cancer under the age of 50 have Lynch syndrome. It's common in the general population, with up to 1 in 230 people having Lynch syndrome. And it's caused by an autosomal dominant inheritance of a mistake or a mutation in one of these mismatch repair genes. We see families that have multiple cancers, oftentimes at much younger ages than we would expect. We all know that the cancer risks in Lynch syndrome are significantly elevated compared to the general population, and today we'll really be focusing on the colorectal cancer risk. So what tools do we have to decrease that significantly elevated risk for our Lynch syndrome patients? Really, the hallmark of colon cancer risk reduction is high quality colonoscopy. We can take advantage of how we understand cancers form in Lynch syndrome because we know that the majority of these cancers start as small precancerous colon polyps that over time can grow and turn into cancer. And so with colonoscopy, we can identify these polyps before they turn into cancer, remove them, and essentially prevent the progression to cancer. Screening in Lynch syndrome works. When comparing groups of patients with Lynch who are screened versus those who aren't, they have a significant reduction in getting colon cancer and a significant reduction in dying from colon cancer. So what constitutes a high quality colonoscopy? Unlike other tests in medicine, there are many factors that go into a high quality procedure. Some of these are related to the doctor doing the procedure in terms of their specialty, their training, how conscientious they are, their knowledge base, both about colonoscopy, polyps, as well as Lynch syndrome. There are certainly organizational or systemic factors, patient level factors such as the bowel preparation quality, the tumor biology, which is important in Lynch syndrome, and then of course, many technical factors of colonoscopy quality. We'll spend some time talking about some of these issues as they relate to Lynch syndrome. We always rate the bowel preparation when we do colonoscopy, and you can see sort of the progression of an excellent prep to a poor prep. And you might think that when we are thinking about these large polyps that can turn into cancer, even with a fair prep, it would be pretty hard to miss a polyp like this. But what's important to understand is that many polyps actually look like this, and these polyps are just as precancerous as the polyp that you see on the right. And so it's no surprise that many studies have been performed that show that the better the bowel preparation quality is, the more likely doctors are to find these precancerous polyps or adenomas. And certainly they're much more likely to find the serious ones, these advanced adenomas. So what makes for a good prep? There's certainly factors from the doctor side as well as the patient side. From the doctor side, we really emphasize the importance of a safe prep and an effective prep. And of course, from the patient side of things, we want to be sure to find a prep that is tolerable in terms of taste and volume and side effects. So for many years, this was really the mainstay of our prep options, this large volume prep that really did not taste very good. And thankfully, over the years, we've had an emergence of many other options, which include over-the-counter as well as prescription-type options. So what's the best prep? Well, as you can see, majority of these preps do actually achieve fairly good preparation qualities for most patients. So the biggest difference really are in the cost of the preps, and then some of these issues in terms of taste, volume, but then also considerations regarding a patient's medical issues that might include kidney problems, heart problems, liver issues, the medications they take. And so really it comes down to balancing all of these things to find the best prep that's customized to the patient in front of us. What's really critically important, regardless of which prep you take, is to do what's called a split dose. That means taking half the prep the night before the procedure and half the prep the day of the procedure. Before we really had split dosing as a standard of care, you can see the quality of the bowel prep, especially in the beginning part or the right side of the colon on the left, versus when a patient gets a second flush of prep the day of the procedure, as the photo shown on the right. And you can see that this residue that develops even after a patient finishes the prep without doing a split dose can obscure these really subtle or flat polyps that are precancerous. So the bottom line really is that we have to pick a safe prep. So tell your doctor about any heart, liver, kidney issues, all the medications that you take. We want to make sure we find a good fit for a prep that you can take every 1 to 2 years as is required for your Lynch syndrome, both in terms of cost as well as tolerability. There's a lot of options to troubleshoot possible side effects or intolerances. We always advise our patients to make sure the prep is as ice cold as possible, to use a straw so that you're not smelling the prep as you're taking it. We often will prescribe medications for anti-nausea effects if patients have queasiness or nausea with the prep, and then can even add some flavoring to the prep to make it taste better. It's important to also adhere to the other instructions that come along with a good quality prep, such as avoiding certain fruits or vegetables that have seeds for a number of days and making sure you stay adequately hydrated, and really most importantly, to make sure you adhere to split dosing. Because really, in the end, we want to partner with our patients to do everything we can to find even the most subtle polyps. And it's almost impossible to see this polyp even in the setting of a pristine prep, maybe a little bit more accentuated with some of the technologies that we have. But these polyps, you can see, can be easily obscured without a good quality bowel prep. So what about the other sort of bells and whistles that we might have? You might see your doctors use something called chromoendoscopy. That's essentially where a chemical substance is sprayed onto the surface of the colon tissue, and there's a variety of dyes that can be used, and they really outline a polyp nicely by being absorbed into the crevices of different areas of the polyp. It does require a pristine bowel prep because that dye not only sort of adheres to the wall of the colon, but can stick to any debris or mucus in the colon. And these are adjunctive techniques that can help improve polyp detection in Lynch syndrome. There are a bunch of other potential techniques or technologies that you may see your doctor use. This is a little plastic attachment that we can put at the tip of the scope that can help us push folds down and look behind, areas in the colon that are hard to see. A variety of cuff or balloon devices to really open up the colon to be able to see it as well as possible. And even these really fancy scopes that not only have a camera that looks forward, but a 270-degree view so that you have essentially almost a full view of the colon with these different camera angles. But really, regardless of all of these different technologies that move the needle forward slightly in terms of colonoscopy quality, the most important thing that really improves colonoscopy quality are the people behind it. The patient who brings the bowel prep and the doctor who really has to understand the subtlety of these polyps that sometimes we're looking for and the special considerations in Lynch syndrome. So let's talk about the endoscopist a little bit. We know that the amount of time that an endoscopist spends looking, the less likely they are to miss cancers. And that might seem like common sense, but there have been clear studies that show that doctors who look in the colon for less than 9 minutes have a significantly higher rate of missing cancers. The time spent is critically important. But it's not just about time. Technique matters, how they spend that time looking. This was a really interesting study that looked at different techniques, including how doctors look at the folds of the colon, how much they open up or distend the colon, and how much they clean away debris. And doctors who had better technique, this purple bar on the left, were much more likely to find precancerous polyps than doctors that had poor technique. So when it comes down to it, there are many factors that go into a high-quality colonoscopy, and it's really important to pair with a GI team that can really optimize the bowel prep for the patient and the inspection technique to decrease the chance of missing polyps and cancer. So what about aspirin? Well, we know from a study published in 2011 that patients with Lynch syndrome who are able to take 600 milligrams of aspirin every day for 2 years, at 5 years down the line, their risk of colon cancer was reduced by 50%. Just this past summer, the 20-year follow-up of this study was published, showing that those same patients who took aspirin for 2 years had a sustained protective effect 20 years out and had a significantly lower risk of developing colon cancer than those who were originally assigned to the placebo group. And so many of us who take care of Lynch syndrome patients, aspirin is a routine part of the discussion that we have. Now, there are still unanswered questions about exactly the right dose of aspirin or how long patients should stay on aspirin, but our recommendation is that patients should take aspirin, and this will reduce their risk of colon cancer. So there have been some recent advances that are important to review. We always think about Lynch syndrome as a single entity and have for a very long time, and we think about these cancer risks that are elevated. But we're learning more and more that the risks associated with colon cancer are really significantly dependent on the specific gene that the patient has mutated. And so you can see that the lifetime risks of these GI cancers are much higher in patients who have MLH1 and MSH2 mutations compared to MSH6 and PMS2. Not only is the overall risk of getting cancers lower in MSH6 and PMS2 mutation carriers, but they tend to get cancers at later ages than the MLH1 and MSH2 patients, with PMS2, for instance, having an average age of colon cancer diagnosis of older than 60 compared to in the 40s for MLH1 and MSH2. So for a long time, we have recommended, and the NCCN has recommended, that patients with Lynch syndrome should have a high quality colonoscopy starting at age 20 to 25 or 2 to 5 years earlier than the earliest colon cancer in the family, and that it should be repeated every 1 to 2 years. However, in the 2020 version of the NCCN guidelines, because of the emerging data on lower risks in PMS2 and MSH6, they updated these guidelines to suggest that patients with PMS2 and MSH6 Lynch syndrome could actually start colonoscopy at age 30 to 35 or 2 to 5 years younger than the earliest cancer within the family, and repeat the procedure every 1 to 2 years. So this is an important change. Certainly for PMS2 and MSH6 families where there are cancers occurring at younger ages, patients should still, in those families, have a colonoscopy 2 to 5 years earlier than the youngest colon cancer. But for many other families where cancers are really not occurring until later in life, colonoscopy can be delayed to 30 to 35. We're also learning more and more about how colon cancer develops in Lynch syndrome. We've all talked about this process of normal tissue developing into a polyp, which can then grow into a cancer. And sometimes this can happen so quickly in Lynch syndrome that this happens between colonoscopies. But we're also learning about different precursors in colon cancer, these mismatch repair deficient crypts that sit under the surface of the colon tissue and can progress to colon cancer without necessarily forming what we expect as typical polyps. And so it really, I think we'll learn more about this different pathway of colon cancer development in Lynch syndrome, and not just the different pathway, but also different modalities to detect cancers earlier in in Lynch syndrome, in addition to colonoscopy. So there's many exciting things to stay tuned about. We'll continue to find ways to improve quality colonoscopy. I think we'll know more about the dose of aspirin. In fact, the dose finding study has already completed recruitment, and so we should know whether 100 or 300 milligrams of aspirin are just as effective as that 600 milligram dose. We'll also have continued personalization of treatment and screening based on genotype, and we'll learn more and more about this non-polyp pathway of colon cancer. So when we take a step back and think about why all this matters, it's not news to this audience, but really it could have made a big difference for our patient. Certainly if his primary care doctor or even the surgeon who took the patient's appendix out would have talked to him about his family history, we could have learned the diagnosis of Lynch within the family before his sister got endometrial cancer, before he got his colon cancer. But really, a large responsibility falls on the GI team, who actually found advanced precancer changes in this young patient. And if at that time, family history would have been put together with the patient declaring himself as high risk based on these polyps, there's a big, big impact we could have made in this man's life and his family. Certainly, we think about the potential cancer we could have prevented if we would have gotten into a 1 to 2 year colonoscopy screening program. We also think about the options we could have offered his wife and his family for pre-implantation genetic testing for the 3 kids he had. And then, of course, his sister, who was diagnosed with endometrial cancer, which is a preventable cancer in Lynch syndrome, as we've learned about. So many opportunities for prevention, and the reasons that we will continue to work hard to improving identification of Lynch syndrome patients. So to conclude, it's incredibly important to be keyed into symptoms, whether you have a confirmed diagnosis of Lynch syndrome or whether there are young patients out there that are being delayed in diagnosis of potentially serious conditions like cancer. High quality colonoscopy is effective at decreasing colon cancer risk, and the bowel preparation quality and your doctor doing the exam are the most critical elements to a high quality procedure. Aspirin is also effective in decreasing long-term cancer risk, and we will continue to learn more and more as this rapidly evolving field progresses. I thank you so much for your time, and I thank the organizers for the invitation to talk with you today.
So since my kids have told me I've said awesome after every speaker, I'm not going to say awesome this time, although it was awesome. So thank you guys for doing this. We got a lot of questions coming in, and I actually want to. I have a question specifically for Stephanie, if she's up for it.
Sure.
You know, we talk a lot about colon cancer, obviously, and given that you have, the what's going on in your brain and everything, do you go through a similar type of regimen for colon cancer screening at this point, and or prevention, as Dr. Patel was talking about with aspirin?
What exactly do you mean? Like if I take aspirin?
Well, I'm saying is, do you go through a normal colonoscopy screening still? For those of us who have had colon cancer, is aspirin part of the regimen currently? Has it been discussed? I'm just curious as to what you go through.
Okay, yeah, so I do my colonoscopy and endoscopies every year. I have one coming up next month. And aspirin, I'm actually supposed to take. I've talked to my doctors about it before, and I'm really bad about taking it regularly. But I'm supposed to take baby aspirin.
Okay. So
with everything going on with me, it's really hard for me to remember to take the aspirin as well. But I'm working on making it a routine because I know how important it is, because I've heard that it does really help prevent colon cancer, and I've already had it and I don't want it again.
All right. Well, we're going to keep an eye on you because we want you back here again next year. So I hope you start taking. That's why, as far as you mentioned the 1 year versus 2 years, different genes have different time frames. I'll be the first to say that my second colon cancer came right after a clear colonoscopy a year previously. So what happens when a patient says, I want to be every year instead of every 2 years, every 3 years, every 5 years, even though it's been clear?
Yeah, I think that's a great question. And, I'll preface by saying that our professional societies in the United States really do recommend every 1 to 2 years. And so that is a discussion that should be personalized between the patient, taking into account their personal history, their family history in terms of polyps and cancer, as well as their preferences. We really do value kind of patient-centered decision-making where all those factors are taken into account. Now, with that said, we didn't have as much time to really go into a lot of these unanswered questions, but this is a rapidly evolving field. And one of the points that was brought up in the chat box is some of the results that have been coming out of this group of investigators out of Europe, the prospective Lynch Syndrome database, that has been tracking patients with Lynch syndrome who are in regular screening programs and their outcomes in terms of how frequently they're getting cancers and what their cancer risks are. And there have been some questions from this group raised about how frequently colonoscopies actually are helpful. And what they have found in a nutshell is that essentially patients getting colonoscopy every 1 to 2 years have the same rates of cancer as patients getting colonoscopies more spread out every 3 years. And so, is it possible to spread things out? I think there's still a lot of unanswered questions when it comes to that issue. And they actually tie into a lot of what we talked about during our presentation. That is a big piece of information that was missing and that is still missing from this data is information on the quality of the colonoscopy. And so completion of the exam, the quality of the bowel preparation, the detection rates, the precancer polyp detection rates of the doctors doing the colonoscopies. So I think, to answer your question, for our patients here in the United States, our current professional society recommendations are to offer colonoscopy every 1 to 2 years. And so we are within those practice guidelines to offer that for our patients. And I personally have an individualized discussion with every single one of my patients and make a shared decision with them about where they stand on that. Now, I do think that we will learn more and more, as we always do, in medicine and in science, where we will be able to hone that practice, both in terms of optimizing quality, but also in terms of understanding exactly what we can gain from colonoscopy, because there are folks in your boat that they've had a pristine, normal colonoscopy or tiny polyps that were removed, and even short of a year have a large obstructive tumor. So there is much to learn about possibly this non-polyp or mismatch repair deficient crypt pathway to colon cancer. And the optimism that I have is that perhaps we'll find adjunctive screening modalities. So in addition to colonoscopy, perhaps there's specialized stool tests that can be done to pick up this other type of precancer or cancer. And so I think it's a stay tuned type of situation.
It also may lead to, we'll circulating tumor DNA testing.
Mm-hmm. Yeah, exactly.
Well, the jury's out on that. But going back to what you alluded to as far as the time as far as spent on a colonoscopy, will we ever get to a point where, let's say, there's the Colon Cancer Coalition seal of approval for a good GI doctor? Because, is there a way to actually time the removal of the scope? Is there some sort of odometer on the new scopes that show how much time is spent? I'm curious. We have it for cars, we have it for everything else. Does it exist?
Yeah, no, that's a great question. So, highlighting one of the points brought up in the chat, how do I know if my GI doctor is a good one?
Well, everybody loves their doctor.
Yeah.
They're always the best, especially my mother-in-laws.
I think a very honest question to ask your doctor is, some of the terminology I used, I apologize if I didn't define it completely, is that term ADR, adenoma detection rate. Okay. That actually means on what proportion of colonoscopies do I do where I find a precancerous polyp. And that's a rate that all GI doctors, number one, should be well familiar with, but also should be tracking. And, their group practices, whether it's a large, private practice group or an academic medical center or a community-based practice, should be tracking that. And so that's the first question that I would ask a doctor, do you track your adenoma detection rates? And a follow-up question would be, if so, where do they stand, relative to the rest of your practice? And do you publish that data, or can you provide that data for me? And I think just hearing the response that the doctor has to that type of conversation can help you gauge how much they prioritize quality of colonoscopy. If they respond by saying adenoma, what? That's a, or if they say, gosh, my, what's that?
Or if they take offense to the question,
Right. Or if they say, "Oh, it's none of your,
your business.
It's none of your business." That's a flag, because many of us are proud of our ADRs, and we're proud of our group practices that, give us these report cards and metrics where we see where we stand next to our colleagues, and for different patient populations, such as my women's ADR, my men's ADR, my Lynch syndrome ADR. These are things that we track. And so I think that's probably a good place to start the conversation, I think, as a starting point.
And for the record, my mother-in-law did hear my last comment, so I need to segue to something else. Anesthesia, any concerns about long-term issues with anesthesia? Again, those of us who have our annual colonoscopy and upper endoscopy.
Yeah, so
I mean, someone like Stephanie, any issue with anesthesia? A, are there any long-term effects? And B, do people, I mean, nausea is an issue, vomiting on the Palisades Parkway, things like that. I mean, it just, options, thoughts?
Yeah, so that's a great question, because just like a bowel prep, when you have to go through this every 1 to 2 years, you've got to find the perfect fit for the anesthesia, because for somebody getting once every 10 years, maybe they can deal with pulling over the Palisade Parkway and, you know, vomiting up half the prep that they just took. But for you, it's not tenable, it's not feasible, and it just increases the chances that you're not going to come back and get your colonoscopy. So when it comes to anesthesia options, there's actually a whole spectrum of options. In fact, there are patients who get their colonoscopies without any sedation at all, and that's very safe, and that's actually the standard of care in a lot of other countries. So that's certainly an option, but most patients don't opt for that. There's sort of this intermediate twilight sedation, what we call moderate sedation. So that's usually a combination of medicines like fentanyl, midazolam or Versed, sometimes other medicines like anti-nausea medicines, or Benadryl can be added into that. And that's really where patients achieve kind of a twilight sedation, where they might be aware of what's going on, but they don't really care. And the vast majority of patients tolerate that cocktail of sedation really well. But there are a subgroup of patients that have nausea from narcotics like fentanyl, or get really, really dozy, sleepy, sort of ineffective for hours, sometimes even lingering through the next day afterwards with that cocktail of sedation. And then a subset of patients who, no matter how much we give them, because they're young, because they have other medicines that they're on, that it doesn't really cause them to fall asleep or be relaxed at all. And so those patients, we actually kind of advance to something that's a deeper level of sedation that many might be familiar with on the call, called Propofol. And that's in most states with the assistance of our anesthesia colleagues. And the nice thing about that deeper level of sedation is that if you have any of those issues of intolerance, nausea, with the narcotics, or excess sleepiness, or not really getting that sleepy at all with the medicines that are given, it's a great medication that achieves a deep level of sedation, is still very safe, and it allows us to complete the procedure in a way that patients tolerate it. But I think the take home, Dave, is really that, again, it's a personalized fit. There are some patients who really do great with any one of those options. So it's sometimes at the beginning, a little bit of trial and error to give feedback to your doctor. This one gave me nausea. Okay, next time we'll pre-medicate you with an anti-nausea medicine. This one made me too sleepy. Okay, let's set you up with a different type of anesthesia. To have these conversations and not feel like you just have to suffer through it on a yearly basis. We can always find a way to make this a humane experience for you.
Got it. Stephanie, I see you're waiting to say something. Go ahead.
Well, I was just going to say, I'm one of those people that didn't do well with just the medication they give you for the colonoscopies. I actually woke up during the first one. So now they have to give me general anesthesia and put me completely out. And then I do the endoscopy at the same time as the colonoscopy. So I actually woke up during the endoscopy and it was horrible.
Sorry, I brought it up.
Very traumatizing.
No, and that's exactly, we just don't want to make this a more disruptive or traumatic experience than it has to be. You're already taking a day off of life, family, work. We don't want to put any additional barriers in front of you. So if there are folks in that dread it, talk to your doctor. We can find a way to make it less dreadful. We certainly don't want it to be traumatic. Like through.
Yeah, no, now it's fine. I do general anesthesia and I'm actually steroid dependent, so I have to have an IV of steroids along with the anesthesia, but it works.
So I got so Swati, you got your fans on here. They're thanking you for saving their lives, which is great. But I got a specific question for you for a specific type of patient. Recommendation for an easier small bowel screening for a child who has no colon, because capsule doesn't always capture all the polyps, and obviously capsules can't remove anything if you find anything. So any recommendations? I'm putting you on the spot on this one, so sorry.
Yeah, no, thank you for bringing that up. It's a challenge. So we know that small bowel cancer risk is increased in Lynch syndrome compared to the general population. There aren't standardized screening recommendations because of some of the limitations that the attendee mentioned, that when we've studied things like capsule endoscopy, we miss things. And so screening hasn't been proven to actually catch cancers at a stage where it makes a difference for patients. But in patients who are at particularly increased risk, there are scenarios in which we do small bowel screening or surveillance, especially if we know that there's polyps. And oftentimes it's complementary modalities that we offer, including capsule endoscopy, alternating with imaging tests that were mentioned earlier in the conference. So things like enterography, and that can be usually through MRI to minimize radiation exposure, but can also be through a CT scan. It's essentially a specialized MRI or CT where the patient has to drink contrast, which might be challenging for a young child. But the images are timed to really visualize the small bowel. Now, with that said, even the combination of doing enterography and capsule isn't necessarily 100% sensitive for picking up small bowel polyps and even small bowel cancer. But at least the combination of those two sort of improve the diagnostic performance of over just capsule.
Cool. So one last thing. First off, I've been given a note that apparently your time of colonoscopy is on your report, so including the duration that it takes for it to be removed. So I did not know that, and thank you for sharing that with me. One question, different GI question: gastrointestinal stromal tumors, prevalence in Lynch. How familiar? Because I'm not.
Yeah, it's not considered. So gastrointestinal stromal tumors are essentially tumors within the GI tract that live under the surface of the tissue. So those pictures that I showed you of polyps, you see sort of that normal tissue and then kind of a polyp on top of it. Whereas GIST tumors essentially live under the surface. So they're what we call submucosal tumors. And as far as we're aware, and of course there's still so much to learn in Lynch syndrome, it's not a typical Lynch-associated cancer. But anytime we acquire kind of multi-generation cancer family history, we certainly take that into account in the context of other cancers within the family or within the person who might raise suspicion for Lynch, but GISTs on their own are not typically associated with Lynch syndrome as far as we're aware.
Awesome. I did it. See, I said awesome again, didn't I? And I'm sure I'm here for my kids, so I apologize. And my mother-in-law. So I've pretty much alienated my entire family, and I will be sleeping in the yard tonight. Thank you guys for doing this. I appreciate you being on, and it's been a great wealth of information.